Hi, and welcome to Newswire LA. I'm your host, Chin Thomasangsi. This week, we're taking a break from the usual hard news and politics we cover, and we're going to focus on the world of entertainment. Joining us this week will be RichGirlNetwork.tv's Joy Parris. Many of you know Joy from all of the A-list events and red carpet events held throughout Hollywood. Well, she's bringing some of those reports to Newswire LA, and we're excited to have her. So without further ado, let's find out where Joy is this week. Tonight, Joy's taking us to Beverly Hills, but she's departing from her usual fare and introducing us to Dr. Joel Aronowitz. Dr. Aronowitz is a prominent Los Angeles plastic surgeon with a reputation built over 25 years for compassionate patient care, refined surgical skill, and a passion to improve lives through leading-edge plastic surgery. The doctor's scope of practice encompasses most areas of cosmetic and reconstructive plastic surgery, with an emphasis on the use of the body's own natural adipose or fat tissues for regrowth and regeneration of body tissues damaged from surgery, radiation, and age with less need for invasive muscle flap surgery and foreign implants. Dr. Aronowitz founded the University Stem Cell Center in 2009 to conduct IRB-reviewed clinical adipose stem cell research, which is not widely available here in America just yet. These highly publicized studies use the patient's own fat stores for breast enlargement and regrowth after breast cancer surgery and radiation treatment. For more on these revolutionary processes, let's go now to Joy Parris, who's with Dr. Aronowitz.
Dr. Joel Aronowitz is performing innovative surgery to help breast cancer patients. Let's sit down with Dr. Aronowitz and find out more.
Well, there's a lot of exciting things going on right now, Joy. It's a pleasure having you, and thank you for coming over to find out about what's new. Breast cancer remains really one of the most serious diseases that affects women's health and their well-being, because whether you have breast cancer or not, it's something that hangs over a woman's head her whole life. The biggest advancement in my view right now that's going on that's lessening the problems associated with breast cancer is the advent of skin and nipple-sparing mastectomy. Old-style mastectomy that we've all come to worry about, that's been a curse for women for years and years, that creates a horrible scar across a woman's chest and a terrible deformity. That operation is slowly but surely going by the wayside. And because we're diagnosing breast cancers earlier, and because women are expressing their concern for the deformity of breast cancer surgery, the surgery is a lot better than it ever used to be. So the skin and nipple sparing mastectomy is the term to remember and to ask about for a woman who has a lump in her breast and is going in for a biopsy or even requires a mastectomy.
But what's the difference between the two techniques?
It's very simple, really. If you think of the breast as having a skin envelope, and that's what we look at, and that's what's so pretty about a woman's breast is the shape of that skin envelope, and then the tissue that's inside that is filling up that skin envelope is where the problem is. That's really the breast tissue. It's not just fat in there and some fibrous tissue like a man's breast. There are glands inside. There are ducts that deliver the milk to the nipple. That tissue is the tissue that forms breast cancer. And that's the problem, not the skin. So this technique allows the surgeon to take out that breast tissue that's the problem, but leaving all or most of the skin intact. Well, because if you look at breast cancer as something that most plastic surgeons are intimately involved in, and if you look at the history of breast cancer over the several thousand years of recorded history, we have evidence that breast cancer has been around in every society on the planet for as long as mankind has had civilization. So it's been there. We don't know what causes it. And we have some clues now with BRCA and other things that tell us that certain women are at a higher risk, but we really don't know what causes the vast majority of breast cancers. And we can't prevent the vast majority of breast cancers. So until we can, how can we reduce the pain and suffering that's associated with breast cancer? And that's what occurred to me as a plastic surgeon, was that there was so much pain and suffering associated with the treatment of breast cancer. How can we do a better job? And the way we can do a better job is by applying the principles that we've learned from plastic surgery, from cosmetic surgery of the breast, to breast cancer. And why shouldn't we? Why shouldn't we try to do a better job cosmetically for a woman who has breast cancer? Ideally, it's a woman who has, first of all, is proactive enough to ask for it. A woman has to be strong enough or have an advocate there for her when she's sitting in her doctor's office to insist upon it. If it's a possibility, then she should have that as an option for her. It may not be for everyone, and certainly there are some contraindications that I'll talk about, but the woman needs to have the wherewithal or have an advocate there with her to insist upon it, because we're in a transition phase like right now, and not every doctor is going to offer it to women. Ideally, then, physically, it's a woman who has a small breast cancer, either doesn't have breast cancer yet, like Angelina Jolie had this operation we're talking about, right, ahead of time, before she developed the breast cancer. So that woman is a perfect candidate. If you don't have breast cancer, but for whatever reason you need a prophylactic operation to remove that breast tissue and reduce your risk of developing it. If you already have a breast cancer that's a small breast cancer that is not already grown up close to the skin, then the skin can be spared. If it's already grown into the skin, or the breast cancer is so large that the skin must be removed to give a safe cancer operation, then it's not such a good operation. So early breast cancer, or breast cancer that's not near the skin.
How closely do you work with other doctors that are doing cancer treatments?
Well, I have to work very closely, because the way that we do it in America in most centers is there's a plastic surgeon who does the reconstruction, and that's me. And then there's another physician, a surgeon, who does the cancer operation, who is going to actually do the skin sparing and nipple sparing mastectomy. And those two individuals need to understand each other well, and they need to work together well, because they're kind of at cross purposes, and there's friction there in terms of what they need to do professionally. So they need to be able to plan things out properly and work together well so that everybody can accomplish their goal.
I know that you are the surgeon that did the procedure for Susan Summers. So can you talk to us about that a little bit?
Suzanne is very generous, as you probably know, about talking about her medical issues. And she absolutely is happy for me to talk about her care, because she really is an inspiration to many women and a good example of how to be proactive, which I think is one of her major lessons to us, is open your mouth, pick up a book, read a book, open your mouth and be informed when you go and visit the doctor. It doesn't, good doctors like to have informed patients, like to have interested in patients. Suzanne had a lumpectomy and radiation, which is a standard treatment nowadays. Her surgery was over 10 years ago, but it's still a standard treatment for a small early breast cancer. You've got a small breast cancer. Okay, what we're going to do is we're going to do we're going to go in through an incision somewhere. We're going to take a lump of breast tissue out, and then we're going to radiate the rest of your breast to protect you from any cancer cells we may have left behind. So that's a common operation now for many women with breast cancer. The problem is that the lumpectomy may be a little tiny lump or maybe a big lump. You know, what's a lump is, you know, in your mind. And it's most women's breasts, when you take out a certain amount of volume, if you've got a very large breast and you take out a little tiny lump, you're not going to see the difference. But if you've got a small or medium-sized breast and you take out a significant amount of tissue, you're going to see a defect, or you're going to have a volume difference. And then the radiation causes a shrinkage of the breast tissue as well, and causes it to get harder and firmer, and those radiation changes persist and even worsen over the years, which is something most women aren't really fully informed about. So what happened to Suzanne after 10, 12 years, one breast is a nice full breast, and the other breast she still has, but it has a smaller volume and it's tighter and firmer, and the two don't match. And this is a very common issue after lumpectomy. The skin is still preserved, which is important, but we need more volume. And what I was able to do for Suzanne was basically an advancement of an existing operation, which is to refill that breast with fat that we've harvested through liposuction from wherever a woman has extra fat, the thighs, the hips, the love handles. And then take that fat and inject it into the breast, or some of that fat. The problem is you can only inject so much fat, and some of that fat dies, and how much of it lives is unreliable. So the idea of using stem cells, which is what I did for Suzanne, and she was really the first case in this study, was to enhance the fat that I'm putting back in by adding stem cells. They're her own stem cells. They're from her own fat, so we're not putting breast tissue back there, but we're just trying to make the fat graft that we're putting back in healthier, more regenerative, and have a better ability to survive and grow.
Can you talk about the recovery time with some of these procedures?
Sure. The recovery time from a skin-sparing or nipple-sparing mastectomy is generally very quick. It's generally quicker than a traditional mastectomy, because basically the doctor, to use a common terminology, is sort of scooping out that breast tissue and then putting some type of tissue back in there, an implant or some other type of tissue in there. But the incisions are fairly small and everything is confined to the breast. So the recovery is typically very fast, and the recovery is typically more severe on an emotional level than on a physical level. For the fat grafting procedures and the stem cell enhanced fat grafting procedures, the part that's in the breast is the recovery is typically very quick. A little bruising and swelling for a few days. Within 3 to 5 days, most of that is gone, and then the fat is growing and is going through its evolution of what's going to live, what's going to regenerate, what's going to be reabsorbed. But that's basically painless. The liposuction sites is another matter. Suzanne, for example, complained a lot more about the liposuction than she did the breast. And the liposuction should be a good thing in terms of improving a woman's figure. It shouldn't create deformities, but depending on how much extra fat she has, if you have a lot of extra fat, it's not going to hurt nearly as much as if you're relatively thin and we're trying to get all the little bits and pieces of extra fat. So that's not a horrible pain like a kidney stone or something, but it is sore, and you're not going to want somebody to come up and hug you in that area for, at least 3 or 4 weeks. I would say all in all, it's about a month before that sort of returns to normal and isn't very painful. Well, I think our center is one of the first because we're interested in being on the cutting edge. We're interested in providing the best care that we can that really advances women's health, and we're not locked into a large infrastructure of delivering radiation in a certain way and with a certain kind of a team. We have a little more flexibility because of that. IORT is an awkward name for something that's very simple. I explained how Suzanne had a lumpectomy and radiation, and her whole breast was radiated, so her whole breast suffered. The whole reason they're radiating the whole breast is so that any stray cancer cells are zapped. It doesn't really immunize you in the future. It just, for that moment where the radiation is going in, if you happen to have a cancer cell dividing, boom, it'll kill it. But it affects the whole breast for the rest of the woman's life. IORT is a way of doing the radiation at the time of the lumpectomy. So Suzanne had to go back and forth about 36 times to have her radiation, and she got her whole breast radiated. Whereas if you're a candidate, what we can do is do the lumpectomy, put a little radiation in right at the time of surgery while the woman is asleep. It only takes 20 minutes. There's a lot of preparation time. The radiation physicist has to be there. The radiation oncologist has to be there. There's a lot of little moving parts. But for that patient on the table, it's something that happens in just a few minutes. It's all done. And then when she wakes up, the area of concern has been radiated, not her whole breast. The amount of radiation that she gets is a lot less. Because the wound is open, we can put a little lead plate in that protects her lungs and her heart from any radiation, so there's no scatter radiation going through her to her chest where it doesn't belong. And she wakes up and Bob's your uncle, you're done.
How do you get it to be more widespread and more, so that everybody has an opportunity?
Sure. Well, that's a frustration to people like me. I can tell you it's IORT therapy has been proven in a very large scale study in Europe. It's accepted by the FDA. The efficacy, that is the effectiveness of it, is well demonstrated. But it's not done more commonly for the same reason that a lot of things aren't done. It's easier for us to do the same thing we've always done. And especially nowadays in medicine where there are more cost pressures, there are more ingrained patterns of referral and treatment, and doctors in general are conservative and don't want to do something outside the normal paradigm. These are all factors that play a role in whether or not this treatment gets done. I think that in the future, we will see this therapy commonly available, but it will be adopted slowly, much as the same thing with the nipple and skin sparing mastectomy. The effectiveness was proven years ago, if you look at the medical literature, but it just is a matter of the end user, which is the patient, opening her mouth and saying, hey, I know there's something better. I want that. And that's what the whole history of women's breast cancer treatment has been from the time that we were doing these radical mastectomies, years ago, till the present. It's been mostly women opening their mouth and insisting on something better. And I think that right now,